Hello students, so now let's start with pharmacokinetics. So pharmacokinetic means pharma means drug and kinetic means just like kinetic energy, it is the movement of the drug inside the body. Now let's make it very simple. Let's imagine you have taken a drug orally. So if you have taken a drug orally, the drug comes into your GIT, stomach and small intestine, and from GIT, the drug will cross cells and finally it will come into the blood. So this first step of crossing a cellular barrier and coming into the blood is known as A. A for absorption. Now, when the drug enters into the blood, it finally reaches to the heart, and this heart will pump the drug or distribute the drug to each and every organ. So this drug will be now distributed to all organs. So the second part we will write is D. D for distribution. Now, this drug is a foreign substance for us. Hence, the body will try to remove this drug out of the body. Now, the drug gets removed in body secretions like urine, sweat, saliva. All these secretions are watery secretion. And in a watery secretion, only a water-soluble drug can be removed. So what happens first? This drug goes to certain organs like liver, and liver converts this drug into water soluble form. And this step of converting a drug into a water soluble form is known as M. M stands for metabolism of a drug. Now if the drug becomes water soluble, finally this drug will be removed in body secretions like urine, and the drug gets removed out of the body, and this step is known as E. E stands for excretion of the drug. That is why this is how the drug is coming and getting removed. That is why first question, pharmacokinetics, it is also known as ADME study. Now can you tell me what does ADME stands for? ADME stands for absorption, distribution, metabolism, and excretion. Now, we will discuss all these parameters one by one, but remember one point initially, that when we will discuss absorption, we will calculate one parameter. That parameter will be BA. BA stands for bioavailability of a drug, that how much drug is coming into the blood. When we will discuss distribution, we will calculate a parameter known as VD, which stands for volume of distribution. And when we will discuss about metabolism and excretion, we will calculate a parameter known as CL. CL will be clearance capacity, the power of a body to excrete the drug outside. Now these parameters, that is bioavailability, volume of distribution and CL, these parameters are known as primary pharmacokinetic or PK parameters. Now, from these three pharmacokinetic parameters, that is BA, VD and CL, we calculate rest every other parameters. Like from these parameters, we will calculate the half-life of a drug, T half. We calculate the initial dose which we give to our patient, which is known as loading dose. And then we gave a dose for long-term maintenance known as maintenance dose. And these parameters, they are rather known as secondary pharmacokinetic parameters. So what are primary pharmacokinetic parameter? BA, VD and CL. So in this section, let's start and discuss the first thing, that is absorption of a drug. So what do you mean by absorption? We have learned that diagram. Just recall that diagram and see the definition. Absorption is cellular barriers a drug has to cross to reach systemic circulation. Systemic circulation, beta, means blood. Now, can you tell me which vessels drains into heart? Is it artery or vein? It is always and always veins. So here, systemic circulation word means veins. So which cellular barrier drug crosses to reach into the vein is absorption. Now, in absorption, we have to learn three things. Those logical three things which we are going to discuss is, first thing is, how does a drug crosses cellular barrier? Through which method a drug crosses cellular barrier? Agreed? After we are done with how a drug crosses cellular barrier, we will decide accordingly the route of administration of a drug. And lastly, we will calculate, finally, if we have decided the route of administration, finally, how much amount of the drug is finally coming into the blood, we calculate that thing. And that parameter is known as bioavailability. So we will calculate bioavailability of a drug. So these are the three main agendas for learning absorption of a drug. So let's start first with what are the different types of cellular barrier and how does a drug crosses cellular barrier. So first cellular barrier by which a drug crosses is simple or passive diffusion. So this is the first method of crossing cellular barrier. Now beta, you all know that this is our cell membrane, and our cell membrane, it is made up of phospholipids. That means lipids means it is fatty in nature or lipophilic in nature. And we know like dissolves like. Only a lipid soluble drug can dissolve in a cell membrane, and after dissolving it can come outside and cross a cell membrane. So in simple or passive diffusion, a lipid soluble drug crosses this lipid cell membrane. So we will write this first part. In simple or passive diffusion, a lipophilic drug, which is lipid soluble drug, crosses cell membrane. Now you can see a word is coming, passive and diffusion. Passive or diffusion means there is no application of energy. So energy is not required, and you know that energy is in the form of ATP. So no ATP or energy is required. Now just think, you are swimming in a river and you are not applying energy. Don't you think you will move along the flow of the river? Similarly, in passive or simple diffusion, when we don't apply energy, a drug moves along the concentration gradient. Along means it will move along the flow. Along the concentration gradient means a drug will always move from high concentration to low concentration. And this simple and passive diffusion, it is the most common method by which most of the drugs, they cross cell membrane. So most drugs, they follow simple or passive diffusion. So this is the most common method of crossing a cellular barrier. Now let's talk about other methods of crossing a cellular barrier. So the second method after simple or passive diffusion is aqueous diffusion. So aqueous beta means water soluble. So in aqueous diffusion, a water soluble drug crosses the cell membrane. So a water soluble drug crosses. But we know our cell membrane is made up of lipids. Water soluble drug cannot cross. Hence, we have special pores on our cell membrane. Let's call those pores as aquaporins. So, a water soluble drug can cross a cell membrane through specialized pores. We call it as aquaporin. So, in aqueous diffusion, a hydrophilic means water soluble drug crosses cell membrane. Again, diffusion word is coming, so no ATP is required. And it occurs with the help of specialized pores known as aquaporins. And where this aqueous diffusion happens, it happens in kidney or nephron. Now, in kidney or nephron, we know there is a hormone known as ADH hormone, antidiuretic hormone. This antidiuretic hormone in nephron increase the synthesis of aquaporins, through which water get reabsorbed. But there are certain drugs which can get absorbed through aquaporins also. One classical example of a drug is lithium. Fine. Now the third method of crossing a cellular barrier is filtration. Now, beta, what happens in filtration? Suppose this is one cell and this is another cell. Can we say the space between two cells? Can we call this space as paracellular spaces? Paracellular spaces means the space between two cells. So in filtration, a drug crosses the barrier by paracellular spaces. So we will write in filtration, it occurs through paracellular spaces. Again, it is a passive process, no ATP is required. Now, can you think about in which organs or tissues there is lot of spaces between two cells? The answer is in capillaries or endothelial cells. Remember, capillaries are the smallest blood vessel and capillaries don't have muscles around it. They only contain endothelial cells like this. And their endothelial cells is separated by lot of paracellular spaces. So the classical example where filtration of a drug occurs is in kidney. You must have heard about a word GFR, that is glomerular filtration rate. So from glomerular capillaries, the blood gets filtered into nephron. Another very important question is when we give subcutaneous injection of a drug, let's say subcutaneous injection of insulin, very commonly used insulin for treatment of diabetes. So what happens when we give a drug into fat? So this is subcutaneous fat. Between subcutaneous fat, we have endothelial cells of capillaries. And from this capillaries, the drug from subcutaneous fat enters into the blood. So subcutaneous injection of insulin gets absorbed into the blood by a process known as filtration. Now the fourth point we will write is endocytosis. Endocytosis, also known as pinocytosis. In endocytosis or pinocytosis, large proteins can be absorbed. But remember, only very few specific large proteins can be absorbed, not all. Like example, one toxin which can lead to food poisoning is botulinum toxin. So when a person eats contaminated food, this botulinum toxin can be absorbed through GIT, through pinocytosis. Another large molecule is vitamin B12. From GIT, it can be absorbed. So B12 and botulinum toxin. So what happens in endocytosis? Suppose this is a large molecule drug. So what happens? This cell, it changes its cell membrane through specific receptor for botulinum toxin and vitamin B12. And this drug gets absorbed into the cell known as endocytosis. This cell membrane covers the drug finally. So this is endocytosis. Next method of crossing the cellular barrier is transport mediated absorption, which is also known as carrier mediated absorption. Now, this carrier mediated absorption is further divided into two types. The first one is known as facilitated diffusion, and the second one is known as active transport. Now let's see the difference between these two. So facilitated diffusion, suppose this is a cell and this cell contains a specialized transporter, and this transporter is also known as pump, just like a motor pump. So it will take or hold the drug, and with the help of this transporter, the drug enters into the cell. Now, what is the difference between facilitated diffusion and active transport is very simple. So what I will do, I will duplicate this diagram. Okay. And I will write that same diagram between active transport, and I will write one additional point. In this transporter or pump, in active transport, I will attach a enzyme known as ATPase enzyme. So this is the basic difference between facilitated diffusion and active transport. Now, can you tell me which process among these two requires ATP? Yes, it's active transport. So facilitated diffusion, as you can see, diffusion word is coming. Here, no ATP is required. So it does not require energy. And in active transport, it requires ATP. Fine. Now, when no ATP is required, no energy is required, you flow along the flow of a river. Along the course of a river, you will flow because you are lying with the passively without any energy. So, the drug will move along the concentration gradient. So, that means a drug will move from high to low concentration. But beta, when you are applying energy, like in active transport, can you flow against the flow of river? Can you move against the flow of river? Yes. So in active transport, a drug can move against the concentration gradient. That means a drug can move from low to high concentration. So beta, any example of facilitated diffusion, any transporter? Yes, we will write a transporter known as GLUT transporter. That is glucose transporters. And any example of active transport? Yes, sodium, potassium, ATPase. So you can see sodium, potassium, ATPase word is coming. Another example we will write is P-glycoprotein. So we will discuss about this P-glycoprotein shortly. Now, any specific drug which gets absorbed from our GIT through facilitated diffusion. So F for facilitated. Facilitated means with the help of transporter. The drug name is 5-fluorouracil. Just write the word 5-FU. 5-FU gets absorbed through facilitated diffusion. Any drug from our GIT gets absorbed through active transport. Yes, levodopa, methyl dopa. They are absorbed through certain transporters, which we call it as dopamine transporter, which are discussed in CNS chapter. Now, let's go a little bit more detail. Now, any transporter which does not require ATP, like example, GLUT transporter, which we discussed in facilitated diffusion, these transporters family, they come under a family of transporter known as SLC transporter. SLC stands for solute carrier transporter. And any transporter which requires ATP, like example, we will write P-glycoprotein. It comes under a family known as ABC family of transporter. Now, ABC family stands for, this question was recently asked, ABC stands for ATP binding cassette. It is known as ATP binding cassette. So there was a question which was asked this year. P-glycoprotein is which type of a transporter? It is ATP binding cassette type of a transporter. So this question was recently asked. So keeping this thing in mind, let's talk about this very famous transporter. You will find many MCQ. What is this P-glycoprotein? Nowadays, many questions are coming on P-glycoprotein. Now, P-glycoprotein is a very important topic, and you will write P-glycoprotein, it is a efflux transporter, a very unique transporter known as efflux transporter. Now, what does it mean? Let's understand that we have discussed various pathway of drug absorption. We discussed that drugs through various pathway was crossing a cell by simple diffusion, aqueous diffusion, facilitated transport, etc. Now, let's say the drug has been absorbed. Now, certain cells of our body, they contain a specialized transporter known as P-glycoprotein. And we know P-glycoprotein is ATP binding cassette. So it must be containing ATPase enzyme. Yes. Now the function of this P-glycoprotein is the drug which has been absorbed, it again throws the drug outside. So it leads to again efflux of a drug. So can we say it inhibits absorption of a drug? So if any drug which is identified by P-glycoprotein is again thrown back, can we say the drug levels in the body will reduce and the effect of the drug inside the body will not come? That is why P-glycoprotein has another name. P-glycoprotein is known as MDR transporter, which stands for multi-drug resistance transporter. It is also known as, some books write MRP transporter. MRP is multi-drug resistance protein. The reason is if the drug will not remain inside the body, can we say the body will become resistant to that drug? The answer is this is the simple way. Now the point you have to understand where this P glycoprotein is present, location. Now to understand location, just remember one point always. P glycoprotein don't want the drug to remain inside the body. It is an enemy of a drug, P glycoprotein. So I will tell you certain locations. Think about it. What will be the action of P glycoprotein? So P glycoprotein is present in GIT, like stomach and intestine. Now think logically, will it increase absorption of the drug or will it reduce the absorption of a drug? Yes, it decreases the absorption of a drug. Similarly, if I say it is present in kidney and P glycoprotein don't want to drug remain inside the body. So think about it. Will it increase the excretion of a drug or it will reduce the excretion? Yes, it will increase urinary excretion of a drug. Similarly, it is present in liver where it increases bile excretion of a drug. And it is also present in blood-brain barrier and placenta. What do you think? The drug will able to enter into this organ? No, it will decrease the entry of drug into this organ so that these organs remains protected. So this is the function of P glycoprotein. Now any drug which is identified by P glycoprotein. So the drug which is identified by P glycoprotein, we call it as substrate of P glycoprotein. And a very important drug you must remember is digoxin. Although there are plenty of other drugs also, but you have to remember only one drug, that is digoxin. So digoxin is a substrate of P glycoprotein. Digoxin is given in heart failure. Now, the importance of this point is there are certain other drugs which can increase the activity of P glycoprotein. We call them as P glycoprotein inducer. And we have certain drugs which can reduce the activity of P glycoprotein. We call these drugs as P glycoprotein inhibitors. So, which drugs act as a P glycoprotein inducer and P glycoprotein inhibitor? And this list is very important. You will find many questions on this list. So the drug which is a P glycoprotein inducer is an anti-TB drug, tuberculosis drug, rifampicin. Rifampicin is a P glycoprotein inducer. It increases the activity of P glycoprotein. And the drug which is P glycoprotein inhibitor, we can remember with the help of a mnemonic, quack. And let's make quacker. Q for quinidine, one drug used in arrhythmia. Verapamil, which is a calcium channel blocker. Please remember, very commonly asked question. The question which was asked this year in INICET was, which of the following drug inhibits ATP binding cassette? They haven't asked about P glycoprotein. They ask about ATP binding cassette or ABC protein. And we know that P glycoprotein is an ATP binding cassette. The option was verapamil. Then A for another antiarrhythmic drug, amiodarone. One antibiotic, clarithromycin. Please remember, very commonly asked. Antifungal drug, ketoconazole. the brother of clarithromycin, that is erythromycin, and one anti-HIV drug, ritonavir. Okay, ritonavir. Now, what is the importance of this inducer or inhibitor? Can we say if we combine inducer and inhibitors with substrates of P glycoprotein, can you remember and recall that substrate of P glycoprotein like digoxin? Don't you think they will lead to drug interaction? And if we combine rifampicin with digoxin, rifampicin increase the activity of P glycoprotein and digoxin will be excreted out in urine. So can we say rifampicin increase the urinary excretion of digoxin? So can you tell me what will be the net effect? Hence, rifampicin reduce the effect of digoxin. So any drug which is a P glycoprotein inducer will reduce the effect of a drug. And similarly, one question was asked and an interaction between clarithromycin and digoxin was asked. If you will combine clarithromycin with digoxin, what will happen? Can we say clarithromycin will reduce urinary excretion? And if the drug has reduced urinary excretion, its plasma concentration will increase. The drug will remain in the blood for longer duration of time and it will lead to toxicity of digoxin. High dose of digoxin can be very dangerous. It can lead to arrhythmias on heart. So this is an interaction which you must remember always. So we have discussed all the pathways of drug absorption. So let's make a summary. So can you tell me the most common pathway of drug absorption? That is simple or passive diffusion. And here a lipid soluble drug crosses the cell membrane in as simple as way. Aqueous diffusion occurs through aquaporins. And which drug gets absorbed? Lithium. Endocytosis, large molecules like botulinum toxin and B12 vitamin. Filtration through paracellular spaces, subcutaneous injections of a drug, let's say insulin. Now, facilitated diffusion and active transport, they both occur with the help of transporter. The only difference is facilitated diffusion, no ATP is required. While in active transport, you can see an ATPase enzyme. So here ATP is required, energy dependent process. So the drug in facilitated diffusion is 5-fluorouracil and drug in active transport is levodopa and methyl-dopa. So this is the summary. And which transporter I have told you produces opposite effect, removes the drug back is drug efflux is by P glycoprotein. So this is the summary of all transporters or how the drug crosses cellular barrier. Now let's talk about the most common method of crossing a cellular barrier, and that was simple or passive diffusion, and this needs greater attention in greater detail. So let's recall. In simple or passive diffusion, we discussed a lipid soluble drug crosses cell membrane. So the drug must be lipid soluble and the drug moves along the concentration gradient. And being a passive or diffusion word is coming, no ATP is required. Now there is an equation, mathematical equation, which tells what is the speed of diffusion, speed of simple or passive diffusion. We call it as rate of diffusion, and that rate of diffusion is governed by a very universal or famous law known as Fick's law. So Fick's law tells us about the rate of simple or passive diffusion. And Fick's law is very simple to remember. Just remember a word cap, and in Hindi you call cap as topi. So cap upon topi. Now C stands for the rate of diffusion, don't you think will be directly proportional to concentration of the drug? Now remember, if the drug is present in higher concentration around the cell, the drug will enter more into the cell. Okay, because it moves along the concentration gradient. Now the second point is this cell membrane, if it has greater area, there will be more absorption of a drug, more crossing. So it is directly proportional to A, that is area of cell membrane. Now just think for a logical second. Where do you think in stomach or small intestine there will be more absorption? The answer is small intestine. Because in small intestine, the area of cell membrane is very high. Why? Because in small intestine, the cell membrane area or surface area increases because the cells are brush border epithelial cells. Then P stands for one coefficient known as permeability coefficient that depends upon the type of cell we are discussing. Every cell will have different type of permeability coefficient. Now just think about if the cell membrane is very thick cell membrane, will it have more absorption or less absorption? More diffusion or less diffusion? Less diffusion. So it is inversely proportional to thickness of cell membrane. So area is directly proportional, thickness is inversely proportional. Now this is just a simple equation. Now let's come back to the common basics. I just told you that in simple or passive diffusion, lipid soluble drugs, they cross cell membrane. So let's understand this concept again in a greater detail. So simple diffusion depends upon lipid solubility. So let's assume there is a drug which is 100% lipid soluble. Now for a second, remember lipid soluble drugs, they are also known as non-polar drugs. And the third name of lipid soluble drug is non-ionic drugs. So if a drug is 100% lipid soluble, can we say it will easily cross a cell membrane by simple or passive diffusion? And most drugs, they follow simple or passive diffusion. Now, on the other side, if I say there is a drug which is 100% water soluble. Water soluble drugs are also known as polar drugs. And they are also known as instead of non-ionic, they are also known as strong ionic drugs. Now, do you think these drugs will cross cell membrane? The answer is no. These drugs do not cross cell membrane. And such example of a drug we can remember as one anticoagulant drug, that is heparin. Heparin is a blood thinner or anticoagulant. It is a highly acidic drug or strongly acidic drug. So think for a second and tell me, if we give oral heparin, will it cross cell membrane? Will it get absorbed into the blood? The answer is no. Similarly, one group of antibiotic known as aminoglycoside, which contains streptomycin, gentamicin, these drugs, because they are highly polar, water soluble, or strong ionic drug, these drugs are not absorbed orally. Okay, so if a drug is 100% lipid soluble, gets absorbed when given orally. If a drug is water soluble, not absorb. But beta, what I have told you are very ideal conditions. Remember, most of the drugs we have in nature, they are not 100% lipid soluble. They are not 100% water soluble. Most of the drugs, remember, they lie between a range. And we call these drugs as weak ionic drugs. Now, why we call them as weak ionic drugs? The reason is very simple. They are neither non-ionic, they are nor strong ionic. So they lie between a range known as, hence we call them as weak ionic drugs. Now, whether this weak ionic drug will cross cell membrane or not, how we determine? But we know one thing. If this weak ionic drug behaves as lipid soluble, it will cross. If it will behave as a water soluble, it will not cross. So for weak ionic drugs, whether they are lipid soluble or water soluble, this thing we determine by a value known as pK value. Okay. So how do they behave? This we determine by a pK value. And this concept of pK value is very important. So let's understand what do we mean by pK value of a drug. So first let me make you understand, then we will write. Suppose sir, this is a media and this media has a particular pH. Agree? Now in this media, what I have done, I have put a drug. Now, when I have put this drug into this media, what I saw, this drug became exactly 50% ionic. Ionic means water soluble. And this drug gets converted, rest of the drug gets converted into 50% non-ionic, which is lipid soluble. So if in a particular pH of media, the drug becomes 50% and 50% ionic and non-ionic, then this pH of the media becomes the pK value of a drug. Agree? So keeping this diagram in mind, let's write the definition of pK value, which is a commonly asked question. pK value is that pH at which a drug becomes 50% ionized and 50% non-ionized. So a drug becomes 50% ionized and 50% non-ionized. This definition was asked. Now, how do we calculate pK value? We must have probably learnt in 11th and 12th also. pK value is calculated by an equation known as Henderson-Hasselbalch equation. Now, according to Henderson-Hasselbalch equation, pK value is equal to pH of media, plus log of non-ionic concentration of a drug divided by non-ionic concentration of a drug. Okay, so pH of media, pK value of a drug. Fine. Now just see that equation again. If I convert non-ionic concentration and ionic concentration exactly into 50-50%, can you tell me the value of log? They will cancel each other. Log value will become 1. And we know log 1 is equal to 0. So this log will be removed. And can we say pK will become equal to pH? So see the definition again, that pK value is that pH at which a drug becomes 50% non-ionic and 50% ionic. Now this is all mathematical things. We have to become doctors, not mathematicians. So let's understand in a more simpler way. Let's say if I write a drug, aspirin. And if I write that pK value of aspirin is 3.5, what does it mean? It means if I put aspirin in a media of 3.5, it will become 50% ionized, 50% non-ionized, and non-ionized drug can be absorbed. Similarly, if I write a drug known as morphine and pK value of morphine is 8.5, it means if I put morphine in this 8.5, it will become 50-50%. Now, pK value of aspirin 3.5 is an MCQ. Now, let's say you have taken oral aspirin. When you have taken oral aspirin or any other drug, do you think every time aspirin will get 3.5 pH of the media? The answer is no. Aspirin will encounter different pH of the media. Like in stomachs, because of HCl, the pH is highly acidic because of HCl. And in intestine, because of bicarbonate, the pH is highly basic, around 8 to 9. So the question which comes in our mind is, sir, what will happen to these drugs if we put this drug in different pH of media? So for that, let's draw a pH scale. So in your 11th and 12th, you must have heard about pH scale. In pH scale, 7 is neutral, 0 is going towards acidic, and 14 is basic. That means aspirin on this pH scale lies out here. This is where aspirin lies. So can we say aspirin itself is an acidic drug? So aspirin itself is a weak acidic drug. And any drug which is a weak acidic drug, we use a word pKa. So please we write pKa. And similarly, morphine lies somewhat out here. So can we say morphine itself is a weak basic drug? So any drug which is a basic, we can use a word pKb. Okay. Now, in this respective media, they become 50-50%. Now remember a rule. Sir, if we put an acidic drug into a media which is even more acidic to it. So if we put an acidic drug into a media which is even more acidic to it, the drug will become more into lipid soluble form. So now 80%, 90%, 95% of the drug will be non-ionic or lipid soluble. Similarly, if we put a basic drug in a basic media, the drug will become more of lipid soluble or non-ionic. And if you put acidic drug in a basic media and basic drug in acidic media, that means in opposite media, acid and base, they form ionic bond. So the drug becomes more of ionic, which you call it as water soluble. So in same media, the drug becomes lipid soluble. In opposite media, the drug becomes water soluble. So please write like this, that weak acidic drug, they become non-ionic in which media? In acidic media. And they become ionic in basic media. Similarly, we will write with weak basic drugs. They become non-ionic in same media, that is basic media, and they become ionic in opposite media, that is acidic media. Okay, so their lipid solubility and water solubility changes. Now beta, why I am using a word weak? Can you tell me why I am not using a word strong ionic drugs? Strong ionic could be strong acid or base. Remember, strong acidic or basic drugs, they are not influenced by the pH of media. They always remain water soluble or ionic. So they are not influenced by the pH of media. In any media, they always remain ionic. So this lipid solubility and water solubility changes with weak acidic and weak basic drug. That is why pK value becomes important. Now, let's understand what is the importance of this pK value in our patient. Let's have a clinical touch to this point. Let's say you have taken a drug orally. Let's say you have taken a drug orally, aspirin. Can we say aspirin has a pK value of 3.5? So let's say you have taken this aspirin drug with pK value of 3.5. It enters to your stomach. Can you recall what was the pH of media in stomach? Because of HCl, the pH of media in stomach is 0 to 1. Now this acidic drug is inside a more acidic media. Can you tell me how aspirin will behave? Can we say aspirin will behave as a lipid soluble drug, non-ionic drug? Because of this reason, can we say aspirin will cross cell membrane barrier? Yes, it will cross cell membrane barrier. And because of this reason, because aspirin behaves lipid soluble, it will enter into the stomach cells. Now, inside the stomach cell, what is the pH? It is similar to our blood pH. So, our blood pH is around 7.4. It is around 7.2 to 7.4. Let's take it as 7.4. Inside the cell, the pH of media is slightly basic. Now, can we say aspirin is an acidic drug and it is inside basic media? How aspirin will behave? Can we say aspirin will become ionized inside the stomach cell? It becomes water soluble because acidic drug is in a basic media. So my question is, will it come outside and enter into the blood? No, sir. Ionic drug or water soluble drug cannot cross cell membrane barrier. Hence, aspirin shows aspirin becomes ionized and aspirin gets trapped inside the stomach cell. We call this as aspirin shows ion trapping inside stomach cells. Agree? And because aspirin gets deposited and trapped inside the stomach cell, aspirin destroys stomach cell. It damages stomach cell, which can lead to a side effect of gastric ulcers. So this is one of the very important implication of pK value. Now, let's talk about the next point, that if we change the pH of the media, how much drug will become ionized, how much it will become non-ionized. So, let's take an example of aspirin again. So, aspirin has a pK value of 3.5. Let's say I have a media and that media pH is 3.5. So, how much aspirin will be lipid soluble? Or you can write non-ionized. And how much aspirin will be water soluble or ionized? In this same media, it will be 50-50%. This is the definition of pK value. Now let me change the pH of media by 1. So if I change the pH of media by 1, let me make it more acidic. Now more aspirin will be non-ionized. So it will become 90% and 10%. If again I will reduce the pH of media by 1, it will become 99%, 1%. Again, if I'll reduce the pH of media by 1, it will become 99.9%, 0.1%. Now, why it is happening? Because we have applied log. In log, remember log 10, the things becomes changed exponentially by a factor of 10. So you can see log 10 is playing role out here. It is because of log 10 value. So the question which comes is, which we have to remember, that change in pH of media by 1, can we say it changes ionization by 10%. It changes ionization by 10%. Why 10%? Because of log 10. So just remember this rule, nothing else. Now, let me ask you another question. If I give basic drug, can you tell me basic drugs, they mainly get absorbed from stomach or small intestine? So I'll make stomach and small intestine for you. So basic drugs, they are mainly absorbed from small intestine. And if we discuss the specific part, most of the drugs are absorbed from duodenum, very less from stomach. Now let me ask you, think logically and tell me, acidic drugs are mainly absorbed from. The answer is again small intestine. Now you must be confused. Sir, how it can happen? Remember, yes, pH plays an important role in drug absorption. But what is the main factor which describes drug absorption? Is the area of cell membrane. Think logically. Intestine is a very big tube with brush border epithelial cells. Stomach is a very small tube without any brush border epithelial cells. So all drugs are mainly absorbed from, whether it is acidic or basics, all drugs are absorbed from small intestine. The reason is greater surface area, which is the main factor that determines the absorption of a drug. So all drugs, whether acidic or basic, they are absorbed from small intestine. But let me ask you this question in a twisted way. Which drugs in greater proportion gets absorbed from stomach? Remember, basic drugs, let's say a basic drug morphine, it gets absorbed 90% from intestine, 10% from stomach. But acidic drug, 80% from small intestine, 20% from stomach. So can you tell me which drug in greater proportion or greater percentage gets absorbed from stomach? It is acidic drug because of pH of media. So pH plays a minor role. So keeping this thing in mind, let's answer this follow-up question. Antacids, they reduce the absorption of which drugs mainly? So antacids, beta, we all know are basic drugs and their function is to neutralize HCl in stomach. So pH of the stomach will become neutral and more drugs were getting absorbed from stomach were acidic drug. So antacids, they mainly reduce the absorption of acidic drugs more. So certain examples of those acidic drugs we can write like anti-epileptic drugs, like phenytoin, valproic acid, and another drug is aspirin. Aspirin is a non-steroidal anti-inflammatory drug. Okay. So antacids, they mainly affect the absorption of acidic drugs. So this is how all we need to remember in how does a drug crosses cell membrane and the most common pathway, simple or passive diffusion, and importance of PK value of a drug.